so great access is critically important in endodontic success. It is essential that we carefully remove all the restorative materials to free up the post to facilitate its subsequent removal. Remember, during access and re-entry procedures, you're going to encounter cements, composites, amalgams. Okay, let's get started, and let's head back to our workstations. Recently, there's been a renaissance in our approach to endodontic retreatment. The great news is we can generally, non-surgically remove post and broken instruments with today's technology. Hi, welcome to Ruddle on retreatment. Today we're going to focus on the non-surgical removal of post and a little later, broken instruments. Historically, when a clinician saw a post in a retreatment situation, concerns arose that its removal could weaken, break, or perforate the root, or set the tooth up for a fracture. In this tape, we're going to show you how to carefully remove post with a little technique and today's technology. Endodontic surgery is still too often selected to resolve failures. Surgery is limited in its ability to predictably eliminate pulp, bacteria, and related irritants from the root canal. In endodontic retreatment, you will encounter posts placed 10, 15, and 20 years ago. Therefore, clinicians need to familiarize themselves with a variety of post systems and configurations. In general, posts can be cataloged into parallel versus tapered, like a cast gold post, non-active versus active, like a threaded post, metallic versus non-metallic, like a fiber post. Additionally, certain fricated teeth are restored using interlocking post systems. Let's look at some of these clinical cases exhibiting these post types. Here we have a large threaded screw post. Notice the canals are underfilled and underextended. This parallel post needs to be removed to address serious pathology in the root canal systems. This tapered cast post is short of the post preparation and is off axis. Here, a massive parallel post has significantly weakened the root. Weighing risk versus benefit, surgery may be best. Another factor that will influence safe and successful post retrieval is the cementing agents. Historically, posts were cemented with classic cements such as zinc phosphate, Duralond, or epoxies. However, with the emergence of new adhesive materials such as composite resins and glass ionomers, posts are frequently bonded into root canals, substantially increasing the difficulty for safe and successful removal. Clinicians should take 3 well-angulated radiographs prior to initiating treatment in order to better appreciate the three-dimensionality of any given tooth. From an endodontic standpoint, preoperative film should include mesial, distal, and straight-on angles. These views will better prepare the clinician for root canal treatment. 3 films, in combination, are more valuable than a single film alone and give us important information as to the buccolingual dimensions of a tooth and root concavities. Importantly, preoperative films show us the length and diameter of a post and if the post is centered in the root canal. The armamentarium of burrs I recommend for endodontic retreatment are number 2 and number 4 round burr diamonds for accessing through tooth-colored restoratives, a transmetal burr for accessing through alloy or precious or non-precious metals, surgical lengths number 2 and number 4 carbide round burrs, a surgical length tapered diamond, and a variety of gates glidens to flare the orifice and provide a smooth transition from the axial walls into the root canal space. Rotosonics is an excellent initial choice to impart energy to loosen and remove some post. The 6-sided, regular tip RotoPro burr simply inserts into any friction grip handpiece. When the instrument is rotated at 200,000 RPMs, its 6 edges produce 1.2 million vibrations per minute. The P5 piezoelectric ultrasonic unit provides unmatched power when performing endodontic treatment and retreatment procedures. This unit affords precise working accuracy and a broad power range, and its unique feedback system enhances safety by automatically regulating tip movement. The Pro Ultra Indo 1 through 5 tips are made of stainless steel and then externally coated with a zirconium nitride abrasive. These ultrasonic instruments can be introduced into small spaces while enhancing vision, improving performance, and expanding clinical possibility. The zirconium nitride coating enhances durability and enables the instruments to sand away materials during endodontic treatment and disassembly procedures. Because of its superb energy transfer, the Indo 1 will frequently dislodge most posts. This ultrasonic instrument has a ball at its working end, which, when kept in intimate contact with a post, maximizes energy transfer and promotes cement bond failure. The Pro Ultra Indo 6, 7, and 8 ultrasonic instruments are made of titanium to provide clinicians with thinner diameters and longer lengths as compared to the Indo 3, 4, and 5 instruments. The Post Removal System Kit is a device that can mechanically engage any obstruction whose cross-sectional diameter is 0.6 of a millimeter or greater. The PRS kit contains several component parts, which we will look at a little later in detail. These are the basic devices you will need for most post-removal cases. The more specific instruments will be discussed in each material segment. So now that we have the general picture, let's roll up our sleeves and develop our game plan for post-removal. An animated molar graphic demonstrates a mandibular molar with previous endodontic treatment. Note inadequate access, core material inside the pulp chamber, and a post. Rotary cutting burrs and abrasively coated ultrasonic instruments are used to fully expose the post. Once we have obtained complete straight line access, the Pro Ultra Indo 1 is activated and moved around the post circumferentially and up and down along its exposed length. Experience suggests most posts can be safely removed in approximately 10 minutes. This is my 10-minute rule. However, ultrasonic procedures generate heat, particularly when removing large conductive metal posts. Therefore, use an external water source to reduce temperature and eliminate heat transfer. We are now looking at the occlusal view. The energized Indo 1 tip continues to vibrate against the post. We can now observe fracture lines in the cement and the initiation of post bond failure. Following post removal, an appropriately sized ultrasonic instrument may be utilized to remove circumferential restorative materials. Here we see an activated Indo 5 breaking up restorative material and a white MAC tip collimating air to blow out debris. With the elimination of the post, attention can now be directed towards selecting the best gutta percha removal scheme. Here we have an animated graphic of a mandibular molar demonstrating straight line access and a fully exposed post within the pulp chamber. When ultrasonic procedures prove unsuccessful, we need a fallback option. The PRS kit affords simplicity in use and provides extraordinary opportunity in predictably removing different kinds of post systems and other intercanal obstructions when ultrasonic procedures prove ineffective. When utilizing the PRS, the first step is to select a transmetal burr. This friction grip burr fits into a high-speed handpiece and its sawtooth blades efficiently machine metal. The transmetal burr chamfers and rounds off the coronalmost edges of the post. This activity is accomplished by moving the head of the handpiece in an orbital pattern above the post drill pivot point. The head of the post is now domed and will create a guide path for subsequent instruments. Next, select the largest trephine that will just engage the post. Again, this latch-type drill is placed in a low-speed, high-torque handpiece and rotates clockwise at 15,000 RPMs. The purpose of the trephine is to machine down the coronal 2 to 3 millimeters of the post, creating a perfectly round cylinder. Before drilling with a trephine, it is useful to place a small amount of lubricant, like RC Prep or Glide, on the head of the post. PEC drilling reduces heat and provides greater cutting efficiency. Attention is focused on the proper trephine post alignment during the drilling phase. The trephine progressively machines down the coronalmost aspect of the post in preparation for the next step. There are 5 tubular taps whose internal diameters range from 0.6 to 1.6 millimeters. Each tap is precisely paired to correspondingly numbered trephines. As an example, using a number 3 trephine dictates the selection of a number 3 tap. The working end of the tap contains a tube that internally has left-handed threads and is approximately 4 millimeters in depth. The proximal end of the tap contains a well-engineered handle that is oversized to enhance motor control, beveled to provide comfort, knurled to encourage a sure grip. Additionally, a torque bar can be inserted through the handle port for added comfort and leverage when removing a large post or an actively engaged screw-type post. A silicone cushion is selected such that it will not be displaced into the access cavity and will distribute the post removal loads evenly over the biting surface of the tooth. This bumper is placed over the working end of the tubular tap. Place the tap over the machine-down post, push it firmly in an apical direction, and screw it on using small quarter-turn counterclockwise rotations. The tap forms threads on the post and is drawn down until snug. Slide the cushion down so it contacts and protects the tooth. Now select the extracting plier from the PRS kit. The screw knob is turned clockwise to activate and open the arms of the plier. This simple action efficiently and safely generates the removal force. The plier's small profile allows for easy access to posterior teeth. Properly mount the extracting plier on the engaged tap. The screw knob is slowly turned and the jaws begin to open. Make certain the compressing cushion is properly protecting the tooth as the building removal loads begin to elevate the post. If the screw knob becomes difficult to turn, place and activate a Pro Ultra Endo 1 ultrasonic instrument directly on the post-engaged tap. Ultrasonic waves of energy transmitted to the post will allow the screw knob to turn with greater ease, which in turn progressively separates the jaws of the extracting plier. This action promotes the safe and controlled liberation of the post. Ultimately, the PRS provides clinicians an important post-removal method that is employed when ultrasonic techniques are unsuccessful. In this maxillary molar, the buildup material is an amalgam core. Amalgam cores can be tedious to remove, so simplify the procedure by progressively brushing away this material, being careful to not foreshorten the post. Be careful that you make the distinction between amalgam and post. They're both colored silver, so we could inadvertently and needlessly foreshorten the post. So just sculpt away very lightly out on the perimeter. This will keep the post intact. If space exists between the axial wall and the post, use appropriately sized surgical ink carbide round burrs or thin tapered diamonds to eliminate remaining buildup material. Once we've eliminated the bulk of the amalgam, and if space exists, use ultrasonics below the orifice to remove restorative materials. When fully exposed, vibrate the post up to 10 minutes with the Endo 1. If the post doesn't budge in that time, then we need a fallback option. The Cavo slow-speed electric handpiece can easily machine down a post with an appropriate trephine. Pumping action will allow the post to be machined down about 3 millimeters. Take the correspondingly sized tubular tap. Short little counterclockwise rotations begin to draw the tap down and securely engage it to the post. Now push the bumper down over the occlusal surface. Next, mount the extracting plier, and if the screw knob becomes difficult to turn, use indirect ultrasonics. Ultrasonics can be employed to further encourage the disintegration of cements. An audible pop sometimes can be heard as the post is loosened and removed from the tooth. Now with the post out, again we're going to encounter cement apical to the post. We can select an ultrasonic parallel-walled instrument used at low intensity to brush cut away and blow out this material. Progress until you see pink gutta percha, and now you can proceed with the appropriate retreatment technique.
Here is a mirrored image of a maxillary central incisor with a porcelain fused to metal crown. The PFM crown is removed, exposing a cast core and post. A curette eliminates residual cement.
Gold is fairly soft, so it's not too difficult to begin to machine this core down. And we're going to machine down the core so that its cross-sectional diameter will approximate roughly the size of the number 5 trephine. Be careful not to needlessly over-reduce the core, because then it could render the post-removal system useless. Slowly and progressively mill the post down.
Smooth off the top of the post and again select ultrasonics, keeping in mind the 10-minute rule. In this instance, I'm using an earlier version of the Pro Ultra 1 to vibrate the post. If after 10 minutes ultrasonics is unsuccessful, proceed to the PRS.
I'll start with a number 5 trephine and I'll machine down the post, but because my reduction was imperfect, you can see that when I pull the trephine off, the number 5, the post is still not theoretically round. So now we just advance right to the next progressive smaller trephine, and by using the 5 first, it allows the 4 to machine down with greater ease, and this will machine a perfectly round cylinder. Okay, with this exposed, we can now select the tubular tap. It's very easy for this to bite and engage soft gold, and it doesn't take too much rotation on the handle to secure and draw down the tap. We'll go ahead and continue rotating the tap handle until it's secure. As usual, we'll use the protective bumpers. Notice with the proximity of the adjacent teeth and their incisal edges, we're using a second, and sometimes we'll find out as we begin to insert the extracting plier that we might even need to place a third one.
This will kick the lower jaw further away from the adjacent teeth so that we can introduce the extracting pliers safely. Slowly and progressively turn the screw knob. If the handle ceases to turn easily, then we employ ultrasonics, as has been previously described.
And ultrasonic energy will pass through the tube, down into the post, and begin to generate cement bond failure. Progress with ultrasonics until the mandrel and apparatus frees up and elevates the post from the root canal system. It's useful sometimes to see the power of the system. With the liberated post, you can see that just 2 or 3 threads are sometimes all that stands between success and failure.
I like to select an ultrasonic titanium instrument because of its smooth, efficient cutting action.
Notice how rapidly it blows up glass ionomer, which was the material this post was cemented with. In a very quick fashion, the canal is completely cleaned and we see gutta percha.
This mandibular molar has a cast post in the distal canal. At times, I remove the clinical crown to dramatically improve vision during my retreatment exercises. The cast core must be reduced to facilitate post removal. A parallel-walled Pro Ultra number 4 can be used circumferential to the post to vibrate and break up cement. Use this instrument at the lowest power that will accomplish the clinical task. This instrument is carried lightly around the post. A brushing action breaks up cement. The amplitude of the tip is maximized and the energy imparted to the residual cement optimized when ultrasonic instruments are used in a light brush cutting action. This is the RotoPro going around the post in a clockwise manner. Remember, its 6 surfaces form 6 edges that impart considerable energy. If the RotoPro loosens the post but does not jettison it out of the canal, then proceed to an efficient ultrasonic instrument, like in this situation, an Endo 2.
Learn to place that instrument between the lateral wall and the post, which will wedge, intend to displace and kick the post up coronally. I'd recommend safety glasses because these posts can oftentimes leave the root at considerable velocity. Now, if you look down that distal orifice, you begin to see that there's a little eccentricity off towards the lingual. the titanium tip rapidly removes obturation material from that, which is no doubt the orifice of a second system.
Here is the occlusal view into a mandibular molar. The preoperative films revealed a threaded post in the distal canal. I am removing core material from the pulp chamber with a Pro Ultra Endo 2. This instrument provides unsurpassed vision because we can look down the shaft of the instrument and our line of sight is such that we can see the tip work and watch it sculpt away and break up debris.
In this case, the chamber has zinc phosphate cement, and it is very easy to disintegrate and blow this material out with ultrasonic energy. We progressively free up the post by using a light touch. The tip of the instrument is very lightly used on the cement, and the Stropco white Mac directs air in a very controlled manner to blow debris up the suction hose. The post is progressively freed up, and as we work into tight areas, like between axial walls, or like in this case, the head of the post,
we'll go to a Pro Ultra Endo 4. This is used at the lowest power setting that will efficiently accomplish the clinical task. Its small profile can work easily between the post and an axial wall, and in tight spaces where the larger Endo 2 would have trouble.
We can even remove cements at the orifice level or slightly below, which will encourage subsequent removal procedures. These instruments are used very, very lightly, and it's surprising how much cement can be blown out. Most post systems, like threaded post systems, have engaging tools, and we can use an engaging tool to try the simplest way to encourage removal. In this case, little short counterclockwise strokes begin to back the post up, and the post is liberated from the root canal. You can look down in the canal at high power, and you can see that about 15x, you can see the thread lines or thread marks in the cement wall.
Here is a maxillary central incisor with a large fiber post. Specifically, this is a Serra post distributed by Brasler.
Ultrasonics is not that successful typically to remove these posts because in the advent of aesthetic dentistry and adhesion dentistry, these posts are substantially more secure in their roots than their metal post counterparts. I'm using the diamond to machine down the top of the post, intentionally without water, to show you how hard these posts are.
Without water, notice the sparks. We can still tap these non-metallic posts. The tap engages and is drawn down, and the post begins to move. Without using the extracting plier, the post is elevated out of the canal. Looking ahead to the future, adhesion dentistry and fiber posts will be a formidable challenge. It is increasingly common for dentists to encounter broken posts confined within the roots of teeth. Weighing risk versus benefit, we need to remove enough tooth structure to fully expose the post, but yet with an eye towards future restorative procedures.
We need to preserve maximum remaining dentin when at all possible. Surgical length diamonds, brush cut circumferentially around the post, flaring the access cavity.
Here we have created a staging platform. This platform will accommodate a parallel-walled, ultrasonic, small-profiled instrument. Continue trephining procedures to expose another 1 millimeter of the post.
The Cavo slow-speed electric handpiece can use a trephine to machine down. I'm going to machine down more of the post, which will preserve lateral dentin. The post is only machined down approximately 1 millimeter. Now the appropriately sized tubular tap is brought into place. Counter rotations, counterclockwise, begin to engage and draw the tap down. In this instance, we're probably only generating 3 or 4 threads on the post. Once it's tight, the rubber cushion is placed down over the top of the tooth if we were to use the extracting plier. But in this instance, the Cavo Coronaflex is going to be utilized. The stirrup is slightly modified at its horseshoe end so that it can rotate through the cutouts of the handle. With the stirrup in place, we can now mount the soldered joints into the mounting bar, and once this is mounted securely, then we're going to select the cable chronoflex. Its tip will move 1/2 millimeter in a very controlled way. The finger activates the tip by moving across the valve. This delivers a very controlled force. This procedure is very safe in non-periodontally involved teeth.
Now let's look at a maxillary molar with a cast gold core and interlocking post systems.
My checklist is to think, plan, visualize, execute. The Explorer outlines the palatal post. Transmetal burrs are again employed, but notice that I am removing core material quite far away from the actual palatal post. The burrs tend to chatter as we cut on gold, and if we chatter, we can bounce into the post and we could needlessly reduce its cross-sectional size. By removing the core down 2 or 3 millimeters, we begin to expose the post, but frequently there'll be like a very thin onion skin layer of core still present around the actual post. This is seen here with an Explorer. Don't really waste a lot of clinical time here because we can immediately go to a trephine, and going from big to small, we can reduce that post and throw off all the residual core that was around the post. Very easily we can tap these in the usual manner using protective bumpers to cushion the top of the tooth from the removal loads. And sometimes the multiple bumpers are employed to protect adjacent teeth or to properly get the plier in position in posterior roots. Ultrasonics is commonly used, as you've seen, with the post-removal system because it enhances the removal. Once the palatal post is removed, we're going to have a great shot in through the core looking down into the palatal root. Now we need to progressively remove more of the core to free up the post in the distal buccal. Learn to simplify. Section buccal to lingual to divide the core into mesial distal halves. This not only improves vision and access for the burr, but it will facilitate ultimately the safe removal so that we maximize remaining tooth structure.
Learn to brush cut and keep the burrs off the pulpal floor.
Let's keep our burrs off this area because it would be easy to inadvertently perhaps perforate the furcal floor. Mill down that post with the trephine. Very easy to do in cast as we've seen earlier. We can now engage a tap. It's drawn down and tightly secured. Protective bumpers are used as per usual. Now as we turn the screw knob, many times as it gets tighter and tighter, it resists movement. Learn to use ultrasonics. Hesitate a moment. By hesitating, the constant pull on the post in conjunction with ultrasonics can be very successful and potent at removing a post.
This is an occlusal view of a maxillary molar. Radiographs revealed a large threaded post extending deep into the palatal canal. A surgical length carbide round burr throws the head of the handpiece further away from the occlusal table and allows for the safe removal of a brick hard composite material.
Tapered diamonds are used to true up your axial walls, and surgical length round burrs and tapered diamonds are utilized to remove the bulk of restorative material from the pulp chambers.
Notice the cross-sectional diameter of this post. A Pro Ultra number 6 has a thin parallel wall profile and can fit nicely between the post and the axial wall and can be used to sculpt away restoratives.
A transmetal burr is now selected to machine down the post. Some of these posts have such large cross-sectional diameters that it's wise to mill them down before commencing with using the post-removal system. This will reduce a lot of the trauma of using the trephines and prematurely wearing them out. Notice as we work around the post, metal to metal, we're very steady. Use your offhand, the thumb, and support the head of the handpiece. The machine down post now can receive the appropriately sized trephine. Use a slow speed, high torque handpiece. In kind of a pumping action, we can very easily now mill down the reduced post and make it very round. A tubular tap is placed on the head of the post, and as we go through counterclockwise turns, the tap is pulled down over the post and tightly engages it. To facilitate moving the tap handle in a counterclockwise motion, we use a torque bar. Notice that we're going very slowly and progressively and not rapidly overstressing the post.
Well, we just sheared off the post. Now we need to go back to ultrasonics trephining procedures, albeit more apically, so we can employ a smaller trephine and tap from the PRS kit. Again, turn the tap in small counterclockwise rotations to draw it down.
Having just broken the post, we're going to now use ultrasonics in conjunction with the torque bar. The ultrasonics will transfer energy through the tubular tap into the post, and that will facilitate cement bond failure. Slowly and progressively turn the handle. Flexi screw posts can be a difficult post to remove, and so having just had a breakdown, we're going to spend a little bit more time here to ensure successful removal.
Well, the post just sheared off and is broken for a second time.
You can see then that we need to really be resilient to these setbacks and again have a fallback position. Fortunately, with the microscope and at high power, I'm looking to about mid-root in the Powell Canal. There's a little movement. It's quite encouraging after a few setbacks to see that with a little bit of patience and determination, usually we can be successful. When the post begins to move like this and vibrate, we know it's just a matter of moments before it'll be liberated from the root canal system. Progressively move around the post in a counterclockwise motion, and that will generate the energy necessary to move those flexi post halves and blow them out. It is axiomatic that cement will lie apical to the post. Eliminate it with ultrasonics. Now refer to another tape in the retreatment series on gutta percha removal.
In this show, we have seen the PRS in action several times. Let me make a suggestion when the arms of the extracting plier are too far apart. In these instances, we're pulling the post undesirably off axes. To better direct the removal load forces on axes, we can use thin metal spacer tubes. These spacer tubes can be inserted onto the tap to bring the arms of the extracting plier closer together and better align the removal loads. This preoperative radiograph of a mandibular right second molar bridge abutment demonstrates 3-post, previous endodontics, and apical pathology. Following coronal disassembly, the isolated tooth reveals the core, the heads of 3-post, and a marked protuberance toward the mesiolingual aspect of the crown. The core is sectioned buccal to lingual and then central to mesial in order to divide the buildup into thirds. A diamond burr reduces the buildup and provides deeper access into the pulp chamber. A subsequent photograph reveals progressively deeper sectioning with rotary cutting tools, further reduction of the buildup, and a core carefully sectioned into thirds. An ultrasonic instrument is then utilized to progressively eliminate restorative materials to enhance deeper access. And now we can visualize the pulpal floor liberated of restorative materials and the post free above the orifices. This paves the way for the Pro Ultra Endo 1 using the 10-minute rule. Following post removal, cement is removed from the mesiolingual aspect of the pulpal floor and a displaced extra orifice is identified and the canal negotiated. We can observe the pulpal floor following 3-dimensional cleaning, shaping, and obturation procedures. A post-operative radiograph confirms the disassembly efforts, the smooth flowing shapes, and the packed systems. This radiograph shows incomplete endodontics and resultant failure. Note the poor fitting crown, internal resorption, furcal involvement, and the large post. Circumferential material can be progressively sanded away utilizing appropriately sized Pro Ultra endo tips. A smaller, more parallel instrument may be selected when space is restricted. Here we can visualize straight line access to the fully exposed post, bleeding from the MB1 orifice and evidence of an MB2 orifice system. In this case, I utilized the post removal system. A selected trephine precisely machines the coronal 2 to 3 millimeters of the post. The head of the post is perfectly round and can be tapped. This photograph shows the extracting plier mounted onto the engaged tap, the compressed rubber cushion protecting the tooth from the removal forces, and a previous version of the Endo 1 vibrating the engaged tap. These combined efforts result in post removal. Again, we can visualize the MB1 orifice, related groove, and a likely MB2 system. An off-angled radiograph reveals a well-packed resorptive defect, a furcal canal, and the PFM crown provisionalized. It's good to see on a 4-year recall that there's a new restorative and endodontic healing has occurred. This radiograph of a mandibular right first molar demonstrates a PFM crown, a screw post, and inadequate endodontic treatment. Following isolation and initial reentry, a clinical photograph demonstrates a tap initially forming threads and being drawn down to tightly engage the post. This paves the way for the torque bar, which is then utilized to back the post out of the canal. A post-operative radiograph shows the re-cemented crown and the retreatment efforts. Let's review our technique for post-removal. Gain careful access and remove all pulp chamber restorative materials. Try ultrasonics using the 10-minute rule. The Pro Ultra Endo 1 is activated and used to powerfully vibrate against all aspects of the exposed post. Use an external water source, particularly when removing large and conductive metal posts, to reduce temperature and eliminate heat transfer. If ultrasonics alone is unsuccessful, dome the head of the post with a transmetal burr. Select an appropriately sized trephine and machine down the post with emphasis on PEC drilling to reduce heat and increase efficiency. Once the post has been precisely machined down, a correspondingly sized tubular tap with a protective bumper is rotated counterclockwise to form threads and strongly engage the post. If appropriate, mount extracting pliers. Note the compressed rubber bumper protects the tooth from the removal forces. The energized Endo 1 may be advantageously placed against the post-engaged tap to synergistically facilitate the removal effort. Following post-removal, an ultrasonic instrument may be utilized to remove residual restorative materials. Remember, you will be dealing with a variety of post types and configurations, core materials, and cementing agents, so you'll have to remember to think, visualize, plan, and execute.
A broken instrument is always considered a breakdown for the doctor and patient. It could lower the prognosis by leading to an iatrogenic event, surgery, or extraction. And if these situations aren't devastating enough, the potential for legal ramifications looms on the horizon. In the past, when a clinician discovered a broken instrument, clinically or radiographically, it was generally considered irretrievable. At best, only a select few were expert enough or would spend the time to bypass the obstruction. Frequently, in these instances, the only avenue considered was surgery. Well, that was the attitude in the past. With the advent of microscopes and ultrasonics, the thinking has radically changed. Today, virtually any instrument can be removed by most clinicians, even if it only partially lies in the straightaway portions of the canal. Most clinicians would think of files when we say broken instruments, but the term also applies to the tip of a silver point, the core of a thermophil carrier, a Gates-Glidden burr, a Lentulus spiral, or any man-made obstruction left behind in the canal. This tape will deal mainly with files as obstructions since they are the most common offenders.
Let's look at an animation that will illustrate how a rotary instrument could break in apically merging mesial systems. Mesial canals of mandibular molars at times abruptly merge apically. When the tip of a rotary file reaches the area of confluence, it may roll over, unravel, and break. In this show, we will address how to remove broken, separated, or disarticulated instruments. At this point, let's review those factors influencing breakage. 1. Method of use. Manufacturers publish specific guidelines for instrument use. Deviations from protocol increase the potential for instrument breakage. Clinicians should never use rotary instruments in regions of the canal that haven't been first secured with small hand files. The second cause would be multiple use. In my opinion, an instrument should be discarded after a single case for a variety of reasons, such as metal fatigue, loss of cutting efficiency, and the great variations in length, diameter, and curvatures of canals. In general, if your method of use is appropriate and you discard files after a single case, you should stay out of trouble. However, if you do get into trouble, let's take a look at those factors influencing removal. Several factors need to be appreciated before discussing the techniques utilized for broken instrument removal. The ability to non-surgically access and remove an obstruction will be influenced by its position in the canal. A general rule of thumb is, if 1/3 of the overall length of an obstruction can be exposed, it can generally be removed. The potential to safely remove a broken instrument is further limited by root morphology, including the thickness of dentin and the depth of external concavities. In addition, instruments that lie in the straightaway portions of the canal can typically be removed. Separated instruments that lie partially around canal curvatures, although more difficult, can oftentimes be removed if straight-line access can be established to their most coronal extents. Finally, the type of material comprising an obstruction is another important factor to be considered. As an example, stainless steel files tend to be easier to remove than night-tie broken instruments, as they do not further fracture during the removal process. If the broken instrument segment is apical to the curvature of a canal and safe access cannot be accomplished, then removal is usually not possible, and in the presence of signs or symptoms, surgery or an extraction will at times be required.
One of the advantages of understanding root canal system anatomy is to appreciate that not all canals are round. Let's look at a cross-section of this root. This particular root is frequently quite round, and the canals that are harbored inside the roots are relatively round. So when an instrument gets broken in this canal, the root's relatively round, the instrument is theoretically round, and it makes it difficult to negotiate and try to bypass the fragment, even though with effort and chelators sometimes we can reach the RT. However, frequently on molars, canals are irregular in their cross-sectional diameters, and so when an instrument does in fact get separated deep in the root, we have the opportunity to realize the instrument's only binding on a couple points. We can negotiate lateral to the fragment, and frequently we can negotiate the terminus. Okay, so here's the scenario. You're a good dentist, but you break an instrument. Emotionally, you're devastated, and you panic because you don't have an escape plan. Many dentists would attempt to bypass the obstruction, hope to obturate around it, hoping the patient will be okay. This is obviously not the best solution to the problem. In my experience, the best way to handle this situation is with honesty, integrity, and a plan. The moment you discover you have a problem, your first reaction is the most important if you intend to properly manage the situation. My first rule, count to 10 and take deep breaths. This will calm you so you can think clearly. Second, ask yourself, do I know how to correct this problem? Do I have the tools and skills to retrieve the obstruction? Evaluate, and if you're comfortable, make an effort to manage the breakdown. If successful, then no need for alarm. If unsuccessful, remove the rubber dam and return the patient's chair to the upright position. Having the patient at eye level lessens their sense of vulnerability. In a clear fashion, explain that we have had an unfortunate event. I have broken an instrument in your root. A good way to convey this concept is to show the patient the remaining file segment next to an unbroken file. An X-ray can also be helpful in this situation. Additionally, a simple drawing can be used to explain the various treatment options with the patient, including conventional treatment, possible surgery, extraction, or a specialist referral. Most importantly, have your assistant present and thoroughly document the entire event, including the patient's reactions and intentions. These are the steps to ethically and legally manage a breakdown. As a specialist, I have been referred countless broken instrument cases. When the preceding steps were not followed, oftentimes patients were upset, confused, or angry. In my own practice, I have broken instruments and have had to bite the bullet and come clean. Trying to cover up would only set me up for a legal problem later. Honesty is the best policy. Okay, so we have a breakdown and we need to correct it. Well, fasten your seatbelts and pay attention. We're going to show you a plan that will usually solve the broken instrument dilemma without surgery, without referral, in your own office.
Once again, clinicians should take 3 well-angulated radiographs prior to initiating treatment. Specifically, in broken instrument removal, this allows for better appreciation of the cross-sectional diameter, length, and curvature of the canal, root morphology, and the overall position of the obstruction. Ultrasonics will be your best friend when dealing with a broken instrument. We've discussed the ability to precisely sand away dentin in a controlled manner with these instruments. You will see this advantage demonstrated in broken instrument removal exercises. Specifically, when excellent coronal and radicular access exists to an obstruction, ultrasonic trephining procedures will oftentimes loosen a broken instrument and jettison it from the canal. Sometimes ultrasonic trephining procedures are unsuccessful due to a lack of vision or anatomical restrictions. In these instances, the handle from a stainless steel hand file can be intentionally removed and the shaft of the instrument inserted into a device called the file adapter. The file adapter threads onto the ultrasonic handpiece and its chuck will retain an O2 tapered hand file. Although tedious, small stainless steel hand files can be pre-curved, inserted into available space, and used at low power in an ultrasonic effort to remove a broken instrument. This technique is at times useful when the root is thin and/or the canal is curved. The dental operating microscope is a critically essential part of the armamentarium in non-surgical retreatment. In my experience, Carl Zeiss has a line of superior products. Specifically, the Pro Ergo has magnetic clutches. This feature, in conjunction with rotatable and inclinable oculars, allows us to get into great position for patient care. Doctor stools are important with the armrest feature because it allows us to have shoulder support and lumbar support so we can be comfortable during our procedures. The pistol grip handles allow us to adjust the light intensity, focus, and the zoom feature. The Stropko adapter inserts into a 3-way syringe and is used for directing and precisely collimating air into the operating field. The Stropko allows us to more effectively blow out dentinal dust during ultrasonic use and provides constant vision. This adapter's proximal end is placed in a 3-way syringe, and its distal end has luer lock threads for securely attaching different length and gauged cannulae. Gates Gliddens, sizes 1 through 6, have maximum diameters of 0.5, 0.7, 0.9, 1.1, 1.3, and 1.5 millimeters respectively, and are used to create radicular access and generate a uniform tapered funnel to the obstruction. If greater access is required lateral to the most coronal aspect of an obstruction, the butt of a GG can be modified, as shown on the right, and then used to create a circumferential staging platform. The staging platform is made by selecting a GG drill whose maximum cross-sectional diameter is slightly larger than the visualized instrument. The PRS kit, as seen earlier in this show, contains several component parts that may be utilized to mechanically form threads and engage any obstruction whose diameter is 0.6 of a millimeter or greater. Specifically, the number 1 and number 2 taps provide possibility for the removal of certain obstructions that extend into the pulp chamber. The instrument removal system provides a procedural breakthrough for the removal of intracanal obstructions. There are 3 IRS devices available, and each is a 2-component system designed to mechanically engage broken instruments. Each microtube has a small-sized plastic handle to enhance vision during placement, a side window to improve mechanics, and a 45-degree beveled end to scoop up the coronal end of a broken instrument. Each screw wedge has a knurled metal handle, a left-handed screw mechanism proximally, and a solid cylinder that transitions into an O2 tapered K-type file blades towards its distal end to facilitate engaging an obstruction. We'll see this device in action in a little bit. Our first line of offense to safely remove a broken instrument from the canal is to create great coronal and radicular access to the obstruction. Coronal access is refined with a surgical length tapered diamond burr, whereas radicular access is carefully prepared with a series of Gates Glidden drills used like a brush. Next, we select an appropriately sized ultrasonic instrument that can reach the obstruction. Activate the instrument and move the Pro Ultra Endo tip in a counterclockwise motion around the file, keeping intimate contact between the energized ultrasonic instrument and the broken file. A light touch is mandatory to maximize safety and the ultrasonic tip's efficiency. You'll notice the zirconium nitride coating allows us to sand away minute amounts of dentin as we gently and progressively expose more of the file. As we progress deeper into the canal, a longer length and smaller diameter titanium instrument may be necessary to work safely. In my experience, if we can free up about 1/3 of the separated instrument's overall length, it will begin to loosen, unwind, and usually jump out of the canal. Ultrasonics is the procedural choice when exposing and removing intercanal obstructions lodged deep within the root canal space. However, on occasion, ultrasonic trephining procedures are limited or prove ineffective. In these instances, the IRS may be utilized to mechanically engage and potentially remove the obstruction. Let's see how this device works. When a file separates deep and partially around a curve, it's essential to have straight-line access to the coronalmost aspect of the obstruction. The microtube is then introduced with the long part of the bevel oriented to the outer wall of the canal curvature. The beveled end of the microtube is designed to scoop up the head of the broken file. When the microtube is fully seated, the screw wedge is introduced by rotating and advancing its handle counterclockwise. The screw wedge then engages and displaces the head of the file out the side window. Now remove the obstruction by rotating the assembly out of the canal. In combination, microscopes and ultrasonics have driven microsonic techniques that have improved the potential, predictability, and safety when removing broken instruments. Let's take a look. Here's a case we saw earlier in the show where we removed a crown and post. Let's watch how to remove a broken instrument in the apical 1/3 of this root canal. Titanium endo-ultrasonic instruments are used because their small profiles work deep in the root canal space.
Importantly, their small profile gives us unsurpassed vision. The instrument's smooth cutting action and high tip energy allows us to thermal soften gutta percha. By softening the gutta percha, it allows the tip of the ultrasonic instrument to progressively work circumferentially around the broken obstruction. This is a nickel titanium file, and you can begin to see it move, and at higher mag, you can see the cutting action is progressively freeing up the head of the instrument. Ultrasonics is always performed cutting dry. We don't use water because water, in the presence of debris, would form a sludge or a slurry which would block our vision. The stropco very efficiently blows this debris out, which keeps our vision on the obstruction at all times. This keeps us centered in the root and prevents us from performing iatrogenic events. As you can see, we can progress to smaller profile titanium instruments, which will put us deeper in the canal safely and preserve maximum remaining dentin. The idea is to get this obstruction to move and to begin to get it to vibrate and to wiggle. Gently tap down in an apical manner, and that'll tend to kick the broken obstruction out of the canal. Floating and suspended debris can then be suctioned out of the tooth.
Here's a mandibular molar we saw earlier in the show. Notice a broken file deep within the MB root. It's partially around the curve. During removal techniques, it is wise to place cotton pellets over any other exposed orifice to prevent the nuisance reentry of the fragment into another canal system.
Great radicular access is critically essential to expose and visualize the obstruction. Clearly, we're going to need the small profile of a titanium instrument. We need to be very mindful of external root anatomy. In this case, we don't take the ultrasonic instrument circumferentially around the fragment because that would weaken the tooth or predispose to strip perforation. As we vibrate just basically directly on the head of the broken instrument, sometimes this will loosen it and it'll kick the instrument up and we miss its departure. To confirm that the instrument is actually removed, we use a pre-curved tin file. And by pre-curving the instrument, we can easily then insert it into the canal, and oftentimes then it'll just drop to place. Reorientate the file.
Unidirectional stops help us understand our orientation, and a patency file confirms the instrument is out of the canal. Preoperative films revealed that this maxillary molar has a broken stainless steel file deep within the MB root.
Cotton pellets are placed over the palatal orifice and the distal buccal orifice to prevent nuisance reentry during retrieval efforts. We can then select a Gates-Glidden drill, and in this case it's a 6. The 6 begins to plane up the MB line angle, and we also use the very tip of the bud to face off the orifice. Additionally, the belly of the bird can be used on the lateral aspect of the MB canal towards the MB2. This action begins to reveal the groove that typically road maps over to the MB2 orifice. GGs are used small to big, progressively stepping each larger GG out of the canal. This provides an excellent deep view of the broken obstruction.
Here we employ an ultrasonic titanium endo number 7.
Keep the instrument's tip in intimate contact with the broken obstruction. Move the instrument in a counterclockwise rotation to encourage unwinding. Oftentimes, to get further around the instrument and deeper, revert to a zirconium nitride number 5. Ultrasonics is continued, but sometimes, even though the instrument is moving, it still resists removal. In this instance, then we used the instrument removal system. This is a prototype. It's placed into the canal and is pushed firmly to place. This will kick the head of the file out through the cutout window, and you can see this provides an enormous mechanical advantage and success in removing broken files.
In this mandibular molar, we removed the clinical crown to improve access. A preoperative film revealed a deeply positioned, broken instrument around the curve and close to the furcal side concavity.
There's been a continuous discussion about the importance of great coronal and radicular access. Gates-Gliddens and diamonds are used to establish this access. Larger GGs are used to face off the orifice. That allows us then to bring in tapered diamonds, and we can flare back the mesial axial wall. This will improve our access into the middle 1/3 of the root. Smaller GGs then are used in a crown-down manner. These GGs are tapped very lightly into the canal. I want to emphasize the light pressure that we use the Gates-Gliddens with. It would be analogous to writing with a pencil without breaking the lead. Slowly and progressively, crown down, and we're going to need to crown down until we can visualize the top of the broken instrument. Ultrasonics can really only work in the straightaway portions of the canal. Ultrasonics will not be able to pass lateral to the instrument and around the curve. So if we can expose just perhaps 1 or 2 cutting flutes of the coronalmost aspect of the broken file, we're going to be in good shape.
Small hand files could be utilized in efforts to bypass the file. If hand files could create space lateral to the file, then the ultrasonic file adapter method could be employed. However, I will use a prototype IRS. Notice this pre-market version has no handle.
The long part of the bevel is placed towards the outer wall, which will urge and encourage the broken instrument up into its lumen. Place the microtube and support it with a plier. Drop a tin file through the coronal end until it meets resistance. Push the tin file intentionally towards the foramen to securely wedge and bind the broken instrument between the file and the internal lumen of the microtube. When the apparatus is removed, it's pretty exciting to see that the broken instrument is retained. Notice its curvature and notice all the debris on its cutting flutes.
Clearly, this broken instrument was very securely bound in the root. Here's a maxillary molar with a sectioned silver point in the DB root. The removal procedure was performed live during the Chicago midwinter meeting. Use small hand files in the presence of a chloroform solvent to remove cement and progressively create space lateral to the obstruction.
As we progressively pick in short amplitude strokes, the tin file will progress deeper into the canal. This will put more sealer into suspension. And by moving the tin file circumferentially around the silver point, it's an opportunity to place the next larger sequential instrument. Fresh irrigant is encouraged. The 15 file is inserted. Again, the short picking motions encourage more dissolution of sealer. Flush, aspirate, flush, aspirate. This gives us great vision. At high mag, we can see how really exposed this silver point is. This will allow a 35 headstrom to be placed in the canal. Its cutting flutes will firmly engage the soft elemental silver. The extracting plier from the post-removal system is mounted, and by turning the screw knobs, the arms progressively open, and this force elevates out the silver point.
Here is a working film of a maxillary right second molar. Notice a broken instrument in the DB root and an instrument that has negotiated the palatal canal. Notice in this working film I'm showing a more traditional method of bypassing the broken instrument with a small negotiating file. The postoperative film shows the retreatment efforts, and the broken instrument has been entombed during obturation. Here's a preoperative radiograph of a hemisected molar, and the remaining mesial root is endodontically failing. Note a short screw post, a separated instrument, and amalgam debris from the previous surgical procedure. A clinical photograph shows the splint removed, the post out, and an ultrasonic instrument trephining around the broken file. A subsequent working film demonstrates 2 instruments negotiating the MB and ML systems and at length. This working film shows 2 gutta percha cones at length in the MB and ML systems. A post-treatment radiograph reveals 3-dimensional retreatment. Note the 3rd mesial system between the MB and ML canals with its own apical portal of exit. The 8-year recall film demonstrates a new bridge and excellent periradicular healing. In this preoperative film of a mandibular first molar, notice a broken instrument in the apical 1/3 of the mesial root. Notice the root is thin, and the angle between the file and the coronal 2/3 of the canal. A photograph shows straight line access and the head of the broken Nitai file predictably lying on the outer wall. I utilized a prototype IRS device to scoop up the obstruction, and a subsequent radiograph confirms the removal of the broken file. The post-treatment film demonstrates the pack. Notice the furcal canal and the distal system bifurcating apically. Here's the preoperative radiograph of a temporized maxillary canine and an instrument broken deep in the apical 1/3. A working film shows that the IRS has successfully engaged and partially elevated the deeply positioned file segment. And the postoperative film reminds us of the necessary retreatment steps. Note the densely packed system and the 3 apical portals of exit. Here's a challenging case. A distal oblique angled preoperative film of a previously endodontically treated and surgerized first molar. Note the previous access. A broken instrument off-centered in the root. Apisected roots and a possible MB2 system. A clinical photograph demonstrates straight line access and complete visualization of the broken instrument. Notice the circumferential staging platform to facilitate ultrasonics. This was accomplished with an appropriately sized, modified GG. Notice also the previously untreated MB2 orifice. A clinical photograph shows the Endo 4 ultrasonic instrument trefining counterclockwise around the broken instrument, and subsequent documentation reveals the coronal displacement of the broken file. A 6-month recall radiograph demonstrates excellent progressive healing following the placement of resorbable barriers in the palatal and DB canals. Barriers allow for controlled and hydraulic 3-dimensional obturation. Let's review the technique for the removal of a broken instrument. First, create great coronal and radicular access. To conserve dentin, the radicular preparation should be no bigger than it would have otherwise been prepared if there was no broken file. When necessary, a staging platform may be created with a modified GG to facilitate the subsequent placement of an ultrasonic instrument. Maintain intimate contact with the broken file. Move in a counterclockwise direction and precisely sand away dentin to progressively expose the coronalmost aspect of the broken file. Depending on the root's dimensions and the depth of an external concavity, a longer length and smaller diameter titanium instrument may be utilized to safely conserve dentin and successfully displace the broken instrument. As a reminder, the final preparation should be no larger than it would have been if there was no broken instrument. Sometimes, however, ultrasonic trefining procedures prove unsuccessful. In these instances, use the IRS option. The microtube is introduced so its beveled end is oriented towards the outer wall of a canal curvature. This facilitates scooping up the head of the broken file. Once the microtube is fully seated, the screw wedge is inserted and internally approaches the broken file when rotated counterclockwise. The screw wedge then engages and displaces the head of the file out the side of the window, allowing for a strong mechanical purchase and the removal of a broken instrument. Remember, to break an occasional instrument is human. To retrieve one can be divine. During this tape, we have discussed the successful strategies and techniques to remove post and broken instruments. In all human endeavors, words are words, explanations are explanations, promises are promises, but performance is reality. Training, practice, and technology are the stepping stones that create a winning performance. Speaking of performance, let me make the distinction between 2 games we simultaneously play at all times. One is the outer game, and the other is the inner game. The outer game is a measurable event. Examples could be winning a sporting competition, winning in business, or in endodontics, successfully removing an obstruction. The inner game is developing a winning attitude and achieving the confidence to overcome fear, doubt, and failure. Confidence is what's left when doubt is removed. Challenges can be a form of competition where we welcome difficulties. Welcome retreatment challenges, recognizing in the process you will learn something. Breakdowns present an opportunity for breakthroughs. Trust what you have, identify what you need, be in action, and begin the climb. The climb reminds me of a fantastic experience I had with my family a few years ago. We went on a hiking expedition in the Sierra Nevada mountains. On the 3rd day of our high elevation trek, we made base camp, and by nightfall, plans were laid. Before dawn, my daughter and I were on the trailhead. It was clear and cold. Our goal was to climb spectacular Mount Hoffman. We passed the flowering meadows. The elevation quickly changed.
The trail became steep, requiring strenuous exertion. The challenge began. High up and ahead loomed a vast bowl of boulders. We were awed by the massive scale and phenomenal beauty. The inner game kicked in several hours later as we cleared the tree line. We were reaching incredible heights. The last obstacle was formidable. 3 massive granite faces. Our final assault required a free climb. Tired and triumphant, we peaked. We won the outer game, but our inner game is what created the result. This experience reminds me of an excerpt from the Scottish Himalayan expedition. Whatever you can do, or dream you can do, begin it. Boldness has genius, power, and magic in it. I hope this tape provides the power and capacity to generate winning results for you. Thank you for your time and willingness to learn. I look forward to visiting you in the next episode of Ruddle on Retreatment. I wish you a safe endodontic climb and great future success.
Le vent m'apporte des bruits lointains, guettant ma porte, j'écoute en vain, hélas plus rien ne vient. J'attendrai le jour et la nuit, j'attendrai toujours ton retour. J'attendrai, car l'oiseau qui s'enfuit vient chercher l'oubli dans son nid. Le temps passe et court en battant tristement dans mon cœur plus lourd. Et pourtant j'attendrai ton retour.